there's a lot of topics to cover, but I'll try to cover the most important ones, and then some of the not so important ones. And as most of you are trainees, I'll concentrate on issues that you may be asked in your exams. Wilms tumor is the most common renal malignant anomaly in childhood. 6 to 7% of all childhood cancer, so it's not a very common cancer, but it is the most common renal cancer in kids under 15 years of age. Usually they present under 5 years of age, so the majority of these kids will present under 5 years of age, 80% of them will, and over 90% will present before the age of 8 years. The one question you may be asked, what's the most common kidney tumor in an infant? So in an infant, the most common is not Wilms tumor. It's a mesoplastic nephroma, so this is the most common infant tumor. So if a kid is born with a renal tumor, the answer is congenital mesoplastic nephroma. Wilms tumor appears a little bit later, and there are different other types of tumors that are not as common, rhabdoid tumors, clear cell tumors, and renal cell carcinoma. You have to think about renal cell carcinoma if it's a teenager. So if it's a 13, 14-year-old that comes forward with a renal tumor, you need to think about the possibility that this is a renal cell. Most of these kids will present with abdominal mass. Some of them will present with hematuria, hypertension, and some of them will have predisposing syndromes. And I'll talk about the syndromes because something that you may be asked in your exams also. The pathology of Wilms tumor is a classic triphasic pattern. You have epithelial, blastema, and stromal. So that's a classic pattern. It's a triphasic pattern of Wilms tumor. The prognostic factors with Wilms tumor are favorable histology versus unfavorable histology. Unfavorable histology, or what is also called an aplasia, has a poorer prognosis than favorable histology. Nephrogenic rests are what are thought to be the precursors of Wilms tumor. There are two different types of nephrogenic rests. There's the intralobar and the perilobar. The intralobar, because they're inside the kidney, they're basically earlier in development, because the kidney develops from outside in. So the inside ones are earlier in development, they're more associated with the syndromes. I'll talk about Weiger syndrome, Dennis-Drash, and then the perilobar nephrogenic rests, the rests present later, and they're associated with syndromes like Becker-Wiedemann and hemihypertrophy. Most sporadic Wilms tumors do not have any type of mutations. It's thought to be something related to the WT1. Only around 15% of them have a mutation, but the ones that do have mutations are the syndromes. So the Dennis-Drash syndrome, which is a WT1 mutation, or Weiger syndrome, which is the deletion of 11p13. So 11p13 is associated with Weiger, Dennis-Drash, 11p15 associated with the Becker-Wiedemann. Dennis-Drash syndrome is the renal or renal anomalies and ambiguous genitalia with Wilms tumor. Duplication, Becker-Wiedemann syndrome, as you know, is associated with macroglossia. Other factors that have poor outcome are the loss of heterozygosity. So the two chromosomes, 16q, loss of heterozygosity, and 1p have poor outcomes. So those are things that today, when we treat Wilms tumors and treat Wilms tumors, the new ways of treating is to try and risk stratify them so that we actually are more aggressive in treating those that have poor outcome, and less so in those that have better outcomes. So we can classify those syndromes into high risk versus low risk of developing Wilms tumor. The high risk ones are the Weiger, Dennis-Drash, some other syndromes, but Weiger and Dennis-Drash are at high risk. They're greater than 20% risk of developing Wilms tumors during the first 8 years of life. The ones that are low risk as the isolated hemihypertrophies, and like we did Wiedemann somewhere in the middle. So the current studies are based on the National Wilms Tumor Studies, along with others, the PSYOP in Europe. All these treatments were based on histology. But as I said, the most recent studies have been risk and try to basically risk stratify these and treat based on the risk for success. And in the future, biology is going to play a pretty strong role in the management of patients with renal tumors. What about imaging? So the current standard of evaluating kids with renal masses is to first get an ultrasound to confirm that it's a solid mass, because an abdominal mass in an infant or a child can be hydronephrosis or UPJ obstruction can present, and that's probably the most common presentation. So you get an ultrasound to make sure that it's a solid tumor. So we're talking about solid tumors. So if it's solid tumor, the current standard is to perform a CT scan of the chest and the abdomen, and currently an ultrasound of the vessels. The chest CT will pick up, is a better test to pick up for lung lesions instead of a chest X-ray. The CT of the abdomen provides us with excellent visualization. In the past, part of the protocols when treating Wilms tumor was to explore the contralateral side. Is no longer indicated. You don't have to explore the contralateral side. The CT scan is good enough to determine if there's contralateral disease. Ultrasounds of the vessels are still recommended, but again, the CT scan is a really good test. Or today we're moving into MRIs, but the CT scan today is a pretty good way of demonstrating involvement of vessels. So as surgeons, our role is to first of all determine is this tumor resectable or not, really minimizing tumor spill. Tumor spill is important. You have to minimize tumor spill, because if you spill the tumor, you've upstaged the treatment. You may end up having a child that you can treat only with chemotherapy, now requiring radiation therapy, which has a high morbidity. Staging intraoperatively, including lymph node sampling, and that's a big thing here, is to really get samples of lymph nodes. Marking the extent of the disease with staples, so that the radiation oncologists, if they need radiation, they can actually give that to the bed, and then central line for chemotherapy. Staged Wilms tumor, there's Wilms tumor stage into 5 stages. Stage 1 is a tumor within the kidney. Stage 2 is outside the kidney, but it's resected. Stage 3 is into Gerota's fascia, venous involvement or lymph node involvement. Stage 4 distant metastasis, and stage 5 bilateral. I talked about biological markers. So whenever we do a resection for Wilms tumor or removal of Wilms tumor, you look for unfavorable histology. You also look for loss of heterozygosity, 1p and 16q we talked about. There's a newer, another 1q gain has been studied in favorable histology of Wilms tumor, and those that actually have poor outcomes. So if there's a gain in 1q, even with favorable histology, the prognosis is poor in those children. So currently, when we evaluate the child with a view, again, it's basically risk stratified. We look at the pathology, what is found in surgery, what is found in radiology, and based on that, manage those kids. So I'm going to go through several scenarios of Wilms tumor and what are the current surgical standards. So this is a 1.5-year-old male, has a left-sided tumor, 8 centimeters in diameter. It replaces the left kidney. The right kidney is normal. The liver and lungs and vessels are all normal. So the next step, so I just wanted to have a raise of hand. I know so just to figure out which type of treatment, the US or European. So how many of you would resect this tumor, go in and do the radical nephrectomy? How many would treat with chemotherapy first? How many would biopsy first? Okay. So there are two different protocols that have been studied extensively. Those are multi-institutional protocol, the North American COG protocol and the SIOP. The outcomes are pretty similar. There are pros and cons for each one of these approaches, but eventually the outcomes are similar. It's not a matter of what one is better than the other. They're both actually pretty good in treating the tumors. There's some pros and cons for each one of these the procedures. The COG, the North American studies will recommend a radical nephrectomy with lymph node sampling for a tumor like that. It's resectable, so you can take it out. The SIOP protocols will start off with chemotherapy. The advantage of chemotherapy is that you will shrink the tumor and hopefully or possibly be able to either do a partial nephrectomy or a better radical nephrectomy without spilling. Again, the SIOP protocol does not involve biopsying those kidneys. So the SIOP protocol, one of the criticisms of SIOP protocol is that you may miss a wilms tumor, number one. Number two, that you may undertreat the tumor because you don't have the tissue, so you don't know if it's favorable or unfavorable histology. You're assuming it's favorable, which most of them are. But so that's the disadvantage of doing the SIOP protocol. But again, both protocols have equal success rates and equal long-term outcomes. Again, if you decide to surgically remove this kidney, you've got to remember their complication rates are around 13%. The most commons are hemorrhage, infections, but then the complications are really associated with the type of tumor. So as a surgeon, you have to determine if it's resectable. So if there's a tumor thrombus and you think that this is a high risk, you're better off by treating it first rather than going in and removing that thrombus. And if the tumor diameter is greater than 10 centimeters, most of us would deem those tumors unresectable and treat with chemotherapy first. And then the other thing that was also interesting in this study was that if the nephrectomy was performed by a general surgeon as opposed to a pediatric surgeon or pediatric urologist, the complications rates were much higher. So the standard treatment in the United States is a radical nephrectomy, ureterectomy, lymph node sampling, and then putting clips on the four corners in case those kids will require radiation. As far as lymph nodes, it's really important to sample lymph nodes, and the likelihood of finding a positive lymph node is greater when more than 7 lymph nodes are sampled. So you have to sample 7 or more lymph nodes. If you don't take the nodes, there's a risk of understaging and undertreating with a high rate of recurrence that has been shown with the lower survival. So it's really important to sample lymph nodes when you do nephrectomy. What about the adrenal gland? This is a study from Vanderbilt that has actually looked into the Nisbets 4 and 5 groups, and the adrenals were left inside in 58% of those, and only 4% of the glands that were removed contained tumors. So the risk of having tumor in an adrenal gland is small, and the 5-year event-free survival is pretty much the same if the tumors were removed, if the adrenal gland was removed or not. But one of the issues that they found with both the Nisbets 4 and 5 is the intraoperative spill was much higher in those that underwent an adrenalectomy. So therefore, removing the adrenal is not mandatory in wilms tumor. What about the ureter? So you have to consider involvement of the ureter if the child presents with hematuria. So if there's hematuria, ureteral obstruction, hydronephrosis, all these are suspicious for a ureteral tumor or intraepithelial tumor. And with those, you may consider doing a cystoscopy with retrograde ureterogram or ureterogram to assist in the diagnosis, and then make sure you resect the entire ureter. What about this kid? This is a 1.5-year-old male. Had a 13-centimeter mass that replaces the entire right kidney. The left kidney is normal. So again, same procedures. Again, one of the things, if you remember the previous slide, this is a 13-centimeter mass. It's greater than 10 centimeters. As I said, tumors that are greater than 10 centimeters have high risk. And secondly, it's on the right side. So because of that, so we probably deem this tumor unresectable and treat with chemotherapy first, mainly because the optic field is limited, the anatomy may be distorted, it's difficult to isolate the right renal vasculature, the capsule may be thinner, and because of those, if the tumor is greater than 10 centimeters, we would consider chemotherapy first to shrink the tumor and then nephrectomy. Again, it's right versus left lesions. The right side is much more difficult to perform these operations on than the left side just because of the anatomy of the renal vasculature. And then again, if you have a large tumor on the right side, you may consider chemotherapy first. What about this child, 1.5 years old, small lesion on the left kidney, nothing else, no tumor thrombus? How would you treat that? Again, it's been shown that kids that are under 2 years of age, if the tumor is less than 550 grams, this is stage 1 tumor, there's no loss of heterozygosity and the nodes are sampled that are negative, those are very low risk patients for recurrence. So the only treatment that is required is surgery without chemotherapy. And I think the future classifications will likely be based on the biologists, so really looking at the biology, the loss of heterozygosity, on all the gains, and then determine treatment based on that. Renal sparing surgery, the adult urologists do a lot of partial nephrectomies, and the potential for renal sparing surgery is there to spare nephrons. So potentially, if you treat with chemotherapy, you potentially can shrink those tumors into small size that you can then perform partial nephrectomies. That's an option. There's this study from University of Connecticut that looks at 60 patients. They did partial nephrectomy, but the problem is that they only found 5 of their 60 patients, or only 8%, and they were able or feasible to do a partial nephrectomy on. So again, the problem with partial nephrectomy right now is that in order to be able to successfully do a partial nephrectomy, as adult urologists, you do a lot of nephrectomy. With pediatric urology, where you only have 6, maybe 8 wilms tumors a year, you don't have the experience that the adult urologists have in doing partial nephrectomy, but that's something that I think should be considered in the future and is considered for bilateral tumors, and we'll talk about bilateral tumors in a minute. Laparoscopic approach, again, there's pros and cons of laparoscopic approach, but a laparoscopic approach has not been studied in pediatrics, again, mainly because of the numbers. People have shown, even in adult partial nephrectomies laparoscopically, there's a very steep learning curve. And so you have to do hundreds of these tumors in order to be good at them. And so if you're doing 6 or 8 a year, the laparoscopic approach is not a good one at this point. What about this kid, at 3 years old, left-sided renal mass with a tumor thrombus, a tumor rupture. So this is the left side, and then you can see that the tumor had ruptured in the retroperitoneum, but there's no other tumor. Again, I think you have to determine if this tumor is resectable or unresectable. If there is diffuse tumor spill, you may deem this tumor unresectable because it's going to be really hard for you to get in there, especially if the tumor has spilled. It's probably the best option is to treat this with chemotherapy first and then come back and do the nephrectomy at a later date. Again, important when you actually do a nephrectomy that you do not spill the tumor, because if it's a low-grade tumor and you spill, what that means is one additional chemotherapeutic agent and for a longer period of time plus radiation. So you basically treat them with 2 significant risks. And doxorubicin has a high risk of cardiac anomalies and cardiac failure, and you're treating with radiation that you'd like to avoid initially. So really, when you're doing those nephrectomies, making sure you don't spill. What about renal vein thrombus? So you actually have a thrombus in the renal vein on the left side going into the vena cava. Again, those are around 11% of cases you would get tumor thrombus. The best treatment for these is to treat initially with chemotherapy. A lot of times you can shrink the thrombus and then come in.